Hello, my name is Andrew B. from the NYU Langone Health Department of Orthopedic Surgery, and in this video we will demonstrate our technique for coaptation splinting. I'd like to thank my fellow co-authors, and these are our disclosures. Coaptation splints have long been used for the initial treatment of humeral shaft fractures. In a larger follow-up study with 620 patients, Sarmiento et al. Again demonstrated the protocol of coaptation splinting for humeral shaft fractures in the emergency room or urgent care setting for a mean of 9 days until transitioning into a functional fracture brace in the office. The deforming forces on a mid-shaft humerus fracture come primarily from the deltoid, pulling the proximal fragment into an abduction, with the biceps and triceps shortening the limb, leading to the characteristic varus and shortened fracture deformity. A careful neurovascular exam is essential when evaluating these patients in the emergency room, as the radial nerve courses posteriorly on the humeral shaft in the spiral groove and is at risk from the fracture. Treatment options for humeral shaft fractures can vary in the initial evaluation between coaptation splinting versus immediate functional fracture bracing, and in the definitive treatment between non-operative and operative treatments. When performing a coaptation splint, there are several pearls and pitfalls. The primary mistake we see are coaptation splints of inadequate length. On the lateral aspect, the splint should be measured to the patient's neck rather than the acromion, and the stockinette can be used to continue as the patient's cuff and collar to keep the splint from slipping down, as seen here. Medially, the splint should rest within the patient's axilla, using a curlix or cling through the splint to keep it from slipping down, as seen here. Another mistake is lack of enough of a valgus mold, as seen here. Due to the characteristic varus deformity, a hand should be placed laterally on the apex of the deformity and medially on the elbow to mold the splint and humerus into valgus. If the patient is able to, despite the pain, abducting their arm for them and having them hold an IV pole allows gravity to pull their humerus into valgus during the splinting. It is important to have all your supplies ready given the complexity of the splint. We prefer a stockinette 3 to 4 inches, about 2 times the length of the measured plaster. Here's our video for a coaptation splint. The patient's arm is abducted and holding an IV pole, as previously mentioned. The splint is measured from the axilla to the patient's neck to ensure an adequate length. And then the splint is rolled out to a thickness of 8 to 10 layers. The splint is then sandwiched between two layers of Humeral, and a stockinette is measured out to be about 2 times the length of the plaster. The stockinette is cut into 2 limbs. Each limb is about the length of the plaster. The splint is then smoothed out in standard fashion. And then sandwiched between 2 separate layers of Humeral. This sandwich splint is then placed into the stockinette by placing your arm through the stockinette, grabbing the splint, and then sliding it through from the end of the stockinette to the base of the split limbs. At the end of the stockinette, opposite of the limbs, a hole is cut through the entire splint, through the stockinette, Humeral, and plaster, and then a cling or a curlix is passed through this hole. The function of this cling allows the entire splint, including the plaster inside the stockinette, to hang suspended by the cling, which will eventually go into the axilla and allow the splint to not slip down. The coaptation splint is then placed with the cling end tucked into the patient's axilla, wrapped around the patient's elbow, and then the limb end passed laterally up over the deltoid. Both limbs of the stockinette are then passed over the patient's neck for a future cuff and collar. After final adjustments of the splint, the free cling or curlix is then tied tightly over the lateral splint to avoid any knot irritation of the patient's shoulder and to secure the medial end of the splint up in the axilla. Now is the time to perform your valgus mold. Demonstrated in the video is the characteristic varus angulation, and so the hand should be placed at the apex of the fracture deformity as well as medial on the elbow to perform a valgus mold. Once the valgus mold is complete, the splint can be wrapped in ACE from the shoulder down around the elbow. In addition, the ACE wrap can start in from the fingers and go proximal up to the shoulder to prevent the dependent edema that occurs after these fractures in the hand. Once the splint is applied, the free limbs of the stockinette that are wrapped around the patient's posterior neck can then be tied to perform the cuff and collar. You can see the lateral limb of the splint ends up by the patient's neck over the acromion, and the medial end of the splint ends in the patient's axilla. Following the coaptation splint, the patient's upper extremity should be given strict lifting restrictions and placed in the cuff and collar as demonstrated in the video to allow the elbow to hang and allow hydrostatic forces to help keep the fracture reduced. The patient should follow up within 1 week for repeat radiographs and transition into a fracture brace, with operative versus conservative decision-making occurring then. Immediate wrist, hand, and finger range of motion is encouraged. Thank you.